Okay, so I think we could probably just move on now. A little bit of very simple thoughts about delivery of intravenous fluids, and by intravenous I appreciate that can be intraosseous as well, but much less common, much more difficult and challenged, but a good clinical lifesaver if needed be. But our main way of doing that is by placement of an intravenous cannula through into a vein in order to deliver boluses or infusions of fluid. There are different types of IV cannulas, and it's important just to get a bit of a grasp of that. Most commonly, the pink cannula delivered is our most common size that's put in just due to ease of ability, and sometimes sick patients are unwell and their vasculature is limited. And I really get and appreciate that any IV line is a good IV line in a sick person. However, there are slight differences in the cannula, and hopefully you guys will know the colours and grades of cannulas, but it really is worth taking a minute just to look at the flow rates associated with that. And I'll not go through Poiseuille's law in the relation between diameter and flow rate. That's a whole bit of physics and science that if you haven't picked it up during your standard grades or GCSEs, then you probably don't need to know about. But the certainly that what I would want to just show and highlight there is that the bigger the cannula, the massive increase in the amount of flow that you can give. So when someone is really sick and requiring big volumes of fluid, big cannulas where you possibly can. I get that any cannula is a good cannula, but certainly it is worth, if you have good access to veins, trying to get a bigger cannula in. At the top of page 4, I've put a little example of just the relative increase. So it's not a linear increase when you go from the one cannula to the next cannula size up. A small increase in the cannula size leads to a massive increase in the flow rate. And so when we've looked at a pink cannula given 60 mils per minute, if you increase that to a grey cannula, you get up to 180 mils, 3 times the flow rate for a cannula that isn't 3 times the diameter. And so just remember that. So where possible, big cannulas. Any line's a good line, but the linear relationship doesn't exist. It's I presume an exponential, but that might be the wrong word. And that applies to extension lines. So just a little bugbear of mine, I've put a picture of an extension line. We don't use them that much in routine pre-hospital practice, but in hospital we're obsessed with putting these octopus or bionectors on, and they just defeat the purpose of putting in a big cannula. So we've put a big, short, fat, wide cannula in, and then putting a long, thin extension line, just to really decrease that flow rate. So, in our pre-hospital setting as well, we don't use many blood giving sets, which are big wide giving sets. We use the normal gravity lines, but just sometimes you might see at our events and other work that we use slightly different equipment. It's worth becoming familiar with them and really testing yourself on the well patient of putting a slightly bigger cannula in. I know that's maybe the rights and wrongs in that, but just have a little thought and cast your mind to that. Then have a little thought about the type of IV fluids that we're administering now. I'm not going into too many details on this, and I might just jump ahead between section 3 and section 4 in your handout that we talk about. So the main fluids that you guys will carry on you is 0.9% saline. So in old terminology, I'm coming from, I think it was 1888 when the term normal saline was first put in to physiology, and old was due to freezing points rather than actual electrolyte component. So just we put that term normal saline to probably one side because it isn't normal and it isn't physiological with plasma, which is the ultimate aim. Is we want what the fluid we give to someone to be the same as what's in the human body. You'll have heard the old adage, or the more recent adage, that says that what a person loses, you try and give them back again. In trauma, we give blood because blood is the best option of what to give. That's what they've lost. In dehydration, someone has lost plasma, physiological fluid, and that's what we should try to give. The easiest and cheapest way and the most practical in the pre-hospital setting at the minute is still sodium chloride. That probably will change and has been slowly changing, and the law actually, one of the few areas where the law is ahead of current practice as opposed to normal paramedic medicine prescribing where the law lags behind. So the law is counted under Schedule 17 of the Human Medicines Regulations, and I've put that in that shows the 3 types of fluid that can be administered by a paramedic. in the UK. So working from the top down, so gelatinins, we'll just ignore those. So nice, good few years ago said that colloids, which are synthetic fluids, so the main ones would be Gelafusin that was used. They had large big molecules that when you put them into the vein, they stayed in the vein for quite a long time due to big proteins and big molecules. However, people were quite allergic to them, and actually they ended up in the long term not really doing very much. So although you would get a small gain in the intravascular space initially, that would be lost down the line a little bit. And so put that to one side. So legally you can administer them, practically we don't do that. So the next two comes sodium chloride and compound sodium lactate, which is commonly known as Hartmann's solution. So sodium chloride, 0.9% is a mixture of sodiums and chlorides. That's all that's in it, with water, and it's not entirely physiological, but is relatively similar to plasma, so relatively isotonic to plasma in the short instance. And by that I mean the same amount of, or roughly the same amount of sodiums and chlorides, albeit that there's a few millimoles different. So in non-massive, in the acute setting, like we're talking the pre-hospital environment, it's actually a reasonably good resuscitation fluid in order to give someone volume, and to follow with that some salts and electrolytes. And so that's why it's so commonly used. However, in the longer term, that your sodium will slowly pick up, your chloride will slowly pick up. And remember, when we give someone extra sodiums and chlorides, water will eventually follow, and so if we put into the intravascular extracellular space, they dissolve between them. The ions can't move intravascularly, so your osmolarity will slightly increase, and then water will start moving. So you'll start getting a hyperchloremic, hypernatremic type phase. The person will be a bit dehydrated, will get a little bit acidotic, and the kidneys won't handle it in the long term. Short term, absolutely fine to use really good resuscitation fluid. Longer term, we need to move away and have a little think about that. And that's mostly the in-hospital maintenance fluid section. We're talking 12 to 24 hours down the line. We use some more hypertonic saline solutions, so you'll have heard of this, and we keep it in our arsenal within, say, medical centres and critical care teams, of 5%, so much more concentrated saline, which contains massive amounts of sodium, is the main one relevant to us. So let's have a think just for your information of when we might use those. If we want to give somebody a big burden of sodium, that's going to put a lot of extracellular sodium. Water is then going to follow that, coming out the way, and so the cells will then shrink as they move water from inside the cells to outside the cells. And one of the key phases we want to see that is intracerebrally. So when someone has a raised intracranial pressure, say after a head injury, we want to decrease that pressure. We want to shrink those cells as much to create a little bit of space, and water will move out the way, from the cells into the interstitium, then into the vascular space, and then be peed out through the renal system. There is some work and evidence looking at using 5% saline for all resuscitation fluids within trauma when blood is not easily accessible. So at the minute, guidelines would say for a paramedic cohort, where there is not a palpable pulse, you might deliver a small aliquot, 125 to 250 mils of normal saline. We'll look at possibly using 5%, the 5% saline for that in the future. The 5% glucose is another option that can be used for a crystalloid solution. So again, it's not synthetic, it is physiological in inverted commas, that's got glucose or a dextrose solution within it. It's got large amounts of water in 5%, so it's very weak, and so that'll cause fluids. When you give that intravascular, so into the extracellular space, a large water component, that will want to dissolve into the cells eventually, and so you'll get intracellular rehydration to that. So in essence, in old money, when it came to maintenance fluids, we gave people a little bit of salt, so a little bit of saline and a little bit of sugar. That was 5% dextrose, and we used to intermittently balance those in maintenance. So not too much saline, not too much dextrose, but a mixture of the two. And you get those as combined solutions, so dextrose saline, which is available as a mixed bag, but not relevant to today. 10% glucose, so you'll know that, and we carry that for the treatment of hypoglycemia, but very concentrated and very hypertonic. We talked about DKA earlier on, so if you imagine simulating that, so putting a lot of sugar into someone's veins, water will then follow out of the cells into the extracellular, intravascular, and then be peed out. So we use small quantities, is negligible, but in large quantities, if we were to use 10% as a resuscitation or maintenance fluid, we'd do harm by that. So, and then the last one would be Hartmann's or Plasma-Lyte that we've talked about a little bit before. So Plasma-Lyte you might not have heard tell of. They're both trade names for a crystalloid solution, which is a little bit more physiological. And by that I mean there's a bit of extra stuff put into it. So there's some potassiums, maybe some magnesiums, a little bit of lactate, a bit of different ions and electrolytes. So these will eventually make them intracellularly, probably not enough to be acute replacement, but what it does do is reduce the sodium burden that comes with a big bag of sodium chloride, and leads to some of those problems, offsetting some of those problems down the line. And so in essence, probably the nicest of all the solutions is a Hartmann's or a Plasma-Lyte, so a balanced crystalloid solution, a little bit more physiological, a little bit kinder to the body. However, downsides, more expensive. There are a few times that it can't be used, such as in liver injuries, but the law allows it to be given. Under the human medicines regulations, is that there's capacity for a paramedic to deliver Hartmann's solution, but at the minute. So in our medical centres, we'll carry a balanced crystalloid, such as Hartmann's or Plasma-Lyte. As for what J.R. Calc says, I'm going to leave that up to you guys. That's I don't have access to that at the minute, but you will do. And that comes down a little bit to a summary of our type of IV fluids that we want to be using and when we want to use them. So in active resuscitation, when someone just needs volume in their intravascular space, it doesn't really matter whether you use normal saline, 0.9% saline, or use a balanced crystalloid, so Hartmann's. And so for our practice, intravascular resuscitation fluid, we want to just give a crystalloid, sodium chloride. Want to hypoglycemia, you're going to choose your 10% glucose. If we ever got to the stage of maintenance, you want a little bit of salt, you want a little bit of sugar, and probably a little bit of potassium added into that, and that comes to a mixture of sodium and dextrose, or bag of sodium chloride, a volume of sodium chloride mixed with then a volume of dextrose, sodium chloride, dextrose, and that would be maintenance. But obviously the best form of maintenance is someone to be able to drink or take some parenteral fluid or enteral fluid themselves through that. I'm going to pause the video now and we'll just swap to our last video, which is about the assessment of someone's fluid status, which is probably the most practical too. And hopefully you can, while we're swapping over, load up your NICE document, because we'll just use that as our main go-to for that. We'll just have a little bit of a talk through the assessment of fluids and take from there.